Hello and welcome to your lecture on organ transplantation. This is Professor Osorio, and I hope you are having a great day. Although we will talk a bit about transplant in general, our focus today will be on kidney transplant. Kidney, liver, and heart transplants are the most common. UC Davis is a heart, liver, and kidney transplant center. Sutter Sacramento does heart. How lucky are we to be in an area where such advanced surgeries are performed? One famous person who has received an organ transplant is Selena Gomez. She underwent a kidney transplant in 2017 due to complications from lupus. Her best friend, Francia Reza, donated a kidney to Gomez, a story that was widely covered in the media and brought attention to organ donation and lupus awareness. Another well-known individual is Steve Jobs, the co-founder of Apple Inc., who received a liver transplant in 2009 as part of his treatment for a rare form of pancreatic cancer. Some organs can be transplanted together, such as the kidney and pancreas, kidney and liver, or kidney and heart. In some cases, the failure of one organ, like the pancreas, can lead to the failure of another, such as the kidneys. Additionally, certain organs, like the liver, can be donated and transplanted in segments. Organ and tissue transplants are regulated by the Uniform Anatomical Gift Act to allow for fair and consistent transplantation laws across all states. Organ transplantation, particularly kidney transplants, is generally considered for patients with end-stage organ failure. For those with kidney failure, transplant offers significant survival benefits over remaining on dialysis. Studies have shown that kidney transplant patients tend to live longer than those who remain on long-term dialysis, as dialysis can lead to complications over time. However, eligibility for a transplant depends on various factors, including the patient's overall health, age, potential for post-transplant success, and availability of a suitable donor. A kidney transplant can greatly improve the quality of life for patients, unlike dialysis, which requires frequent sessions that can be time-consuming and physically taxing. A transplant allows patients more freedom and fewer dietary and fluid restrictions. Many transplant recipients report feeling healthier, more energetic, and able to return to normal daily activities. The most common, the cost of maintaining a kidney transplant is about one-third of the cost of long-term dialysis. While the initial expenses of transplantation, which includes surgery and all the medications involved, are high, the ongoing costs associated with dialysis, such as regular treatments and associated healthcare needs, make transplantation a more economically viable option in the long term. Kidney transplant patients often benefit from increased energy and improved quality of life, as mentioned. Freedom from food and fluid restrictions associated with dialysis prevents further wasting of the body caused by long-term dialysis. They have greater independence in daily activities. However, the following disadvantages must also be considered. They require multiple medications, including lifelong immunosuppressants, potential side effects from those medications, the increased risk due to immunosuppression, such as malignancies, infections, and even death. Kidney allocation is managed by the United Network for Organ Sharing, which prioritizes candidates based on several factors. UNOS takes into consideration the patient's health status and immediate need for a transplant. How long the patient has been waiting for a kidney, the proximity to the donor organ, as organs have limited viability outside the body. The compatibility is crucial, with types B and O often facing longer wait times. A closer match in HLA or human leukocyte antigen typing increases the chances of a successful transplant. Patients under 18 receive higher priority to improve their chances of a longer, healthier life. Currently, around 93,000 people are on the kidney transplant waiting list in the US, but only about 30,000 transplants are performed annually. Less than 4% of patients with end-stage renal disease will receive a kidney transplant. Unfortunately, patients over 60 on the waiting list face higher risks, with nearly half likely to die before receiving a transplant. Recipients for kidney transplant selection must meet several criteria. The candidates must have a confirmed diagnosis of ESRD or irreversible renal failure. An intact lower urinary tract is a must. There should be no preclusion for establishing an external urinary conduit, which is necessary for proper urine drainage after the transplant. They also must be in acceptable cardiopulmonary health. The recipient should have an acceptable cardiopulmonary system without extensive vascular disease, as this can affect both the surgery and the long-term outcome, right? Acceptable gastrointestinal function is also a must. The recipient's GI function must be adequate. However, caution is needed for patients with pre-existing ulcer disease to avoid complications post-transplant. The patient must belong to an optimal age group. The best outcomes are often observed in recipients between the ages of 5 and 50 who do not have other significant health issues that could compromise the success of the transplant. Although there are instances, even for heart transplants, of older adult patients receiving an organ. The last heart transplant I recovered was greater than 70 years old. Recipients are generally well motivated, have demonstrated compliance with medical regimens, and are financially covered for the transplant and its aftercare. Contraindications include disseminated malignancies, untreated cardiac disease, or extensive vascular disease. Certain patients may need surgical procedures like coronary artery revascularization or cholecystectomy to be eligible. Contraindications for kidney transplantation are your metastatic cancers or disseminated cancers, and untreated cardiac disease can complicate the transplant process and long-term recovery. In preparation for transplant, patients may undergo evaluation and procedures to ensure they are fit for transplantation, emphasizing the need for a stable cardiovascular system in the absence of severe psychosis or a history of it. Contraindications to kidney transplantation include active malignancies, especially those that are metastatic, because they pose a high risk for recurrence and complications post-transplant. Persistent infections can increase the risk of post-transplant complications. Severe unmanaged heart conditions can compromise the success of the transplant and the patient's survival. Ongoing substance abuse affects the patient's ability to adhere to post-transplant care, which is very involved. Patients must be capable of understanding the risks and responsibilities associated with transplantation. Patients with a history of not following treatment regimens may struggle with the strict post-transplant care that is required. Poorly managed hypertension or diabetes increases the risk of complications and affects transplant success. The transplant patient listing process involves several critical steps. It begins with a referral from the patient's nephrologist, indicating the need for a transplant. Tests are conducted to determine the patient's blood type, and human leukocyte antigen typing is essential for matching a compatible donor. Testing for viruses such as CMV or cytomegalovirus is conducted to assess the patient's health and reduce potential complications. It's also important for future management post-transplantation. A Doppler ultrasound is used to evaluate blood flow in the lower extremities, ensuring that the patient has sufficient circulation. A chest X-ray is performed to assess the patient's pulmonary health. Patients undergo a thorough cardiac assessment to ensure that they can withstand the surgery. A psychological evaluation is also carried out to ensure that the patient is mentally and emotionally prepared for the transplant process. Because of this workup, a lot of patients end up finding many other issues with their health. We have a good population of cabbage patients that were not cleared cardiovascular wise, so they get their heart and vascular issues fixed first before they get their transplant. This comprehensive evaluation ensures that the patient is a suitable candidate for transplant, reducing potential risks and complications. A living related donor is a donor who has a blood relation to the recipient, such as a sibling, parent, or a child. On the other hand, a living unrelated donor is a donor with no blood relation to the recipient, like a spouse, a friend, or a coworker. Paired donor exchanges is a donation method involving donation chains where donors are paired with compatible recipients. A deceased donor can be obtained after declaring a donor 1 brain dead, where organs are donated after the donor is declared brain dead with consent from their family, or 2 cardiac death, where organs are donated after the donor's heart has stopped beating. These distinctions are important as they affect the availability and compatibility of the donated organs. Living kidney transplants have several key benefits, such as reducing the waiting time for a transplant, lowering the risk of acute tubular necrosis or damage to the kidney, significantly improving long-term survival rates, and providing the option of a rapid donor exchange or a kidney swap to increase donor compatibility and availability. Here is a list of various health conditions and factors that may be relevant medical contraindications to the use of living donors. The conditions listed are kidney disease, diabetes, hypertension, cardiac disease, pulmonary disease, excluding well-controlled asthma with medication, malignancy, excluding primary benign brain tumors and some skin cancers, pregnancy, substance abuse, having only one kidney. These conditions might require special consideration when planning treatment, monitoring health outcomes, or determining eligibility for certain medical interventions, such as kidney transplantation. A friend of mine who works as a flight attendant became a kidney donor. She donated to someone she knew of, though they weren't particularly close at the time. The recipient was the wife of a fellow flight attendant, and they had a young family with a toddler. Demonstrating incredible selflessness, my friend traveled to Seattle for all necessary preoperative checks and compatibility testing. After confirming the match, she texted the recipient saying, "Heard you need a kidney, I am your match." Since then, they have become very close friends. The criteria for selecting deceased kidney donor include donors should ideally be 70 years or younger with a preference for those between 10 and 39 years old. A biopsy might be requested for older kidneys, particularly for donors over 50 years of age, to assess kidney health. The same health requirements apply to deceased donors as to living donors. This slide lists the contraindications for kidney donation based on the donor's present illness, including severe abdominal trauma, because it may cause damage to organs or structures that may compromise the viability of the kidney. Extended periods without blood circulation can lead to kidney damage, making the organ unsuitable for transplantation. Rising creatinine indicates potential kidney dysfunction as well, and untreated sepsis or an active infection can contaminate the kidney and put the recipient at risk. Low blood pressure for extended periods may cause ischemic injury to the kidneys. And lastly, lack of urine production suggests kidney failure or severe damage. For an organ donation to proceed after brain death, the Organ Procurement Organization, or OPO, must verify and document that the donor was pronounced brain dead in accordance with the applicable laws in the city, county, or state where the donation occurs. This is crucial to ensure legal and ethical compliance. In the Sacramento area, the OPO responsible for such processes is Sierra Donor Services. As an astute nurse, follow your employer's policy and procedure regarding when to call the OPO, as most Healthcare organizations, every patient admitted to the ICU or any patient who has been intubated are immediate referrals to OPO. We do not need to be the ones conversing with family. The OPO representative does all that. We just don't want to miss out on a potential organ donation match by not making that referral phone call. For disease organ donation, ischemic time is critical to ensure the viability of the organs for transplant. Ideally, the ischemic time for organs should be less than 24 hours. Transplants can still proceed up to 36 hours of ischemia. However, any duration beyond 36 hours requires special approval from a transplant physician to ensure the best possible outcome for the recipient. Typically, donors and recipients need to have compatible blood types, although research into ABO incompatible donations is ongoing, which might become more common as advancements in immunosuppression occur. Human leukocyte antigen, or HLA, matching is crucial for determining compatibility and reducing the risk of rejection. A cross-match test is performed to see if the recipient has antibodies that would react against the donor's cells. Panel reactive antibody, or PRA, measures the recipient's sensitization level, with a higher PRA indicating a greater risk for organ rejection. Priority is also based on factors like medical urgency, time on the waiting list, and geographical location. This preoperative care focuses on preparing transplant patients both physically and mentally for the procedure. Key steps include determining the compatibility between the donor and the recipient through blood and HLA typing. When I perform a chest X-ray and electrocardiogram to assess overall health, conduct extensive lab tests to check for any potential issues. Literally, I think you send over 20 blood vials for lab. Ensure dialysis as access is maintained, and for peritoneal dialysis patients, the abdomen should be free of dialysate. Secure infusion access for the procedure. Discharge planning and teaching process starts early, educating the patient on post-op care, such as using an incentive spirometry, recognizing signs of organ rejection, medication management, and pain control. You want to provide emotional and psychological support to prepare the patient for the mental and emotional aspects of transplantation. In cases where the transplant is from a living donor, there is more time to plan. However, for non-planned transplants, teaching and discharge planning typically happen well in advance to ensure the patient is ready for the post-operative. Pre-transplant teaching is crucial to prepare patients for the transplant process and ensure the best outcomes. Key points include stress the importance of strictly following the medication regimen and attending follow-up appointments to maintain the health of the transplanted organ. Highlight the necessity of having a reliable support system as family or friends are essential for physical care and emotional support during recovery. You want to encourage patients to consider living donors to avoid long wait times, as transplants from living donors often result in better outcomes. Explain the importance of Explain the importance of tissue typing and cross-matching to ensure the best match between donor and recipient, reducing the risk of organ rejection. Describe the transplant surgery, including the steps involved, the recovery process, and what to expect in terms of hospital stay and post-operative care. Discuss potential complications, including risks associated with the surgery, side effects of immunosuppressive medications, and signs of organ rejection that patients should be aware of. Discuss the indications for native kidney removal, which is not always necessary unless there is significant hypertension. Typically, not functioning kidneys will shrink over time and may not need removal. This is an overview of kidney transplant surgery. This information outlines key aspects of the surgical process for patients undergoing a kidney transplant. They will be under general anesthesia. The surgery typically lasts 2 to 3 hours. There is a 6 to 8-inch incision made in the right or left lower quadrant of the abdomen. Intraoperatively, a Foley catheter is inserted to monitor urine output. A central line is placed to monitor fluid status throughout the surgery and for the next 24 to 48 hours. Again, native kidneys are usually not removed unless they are problematic, like in cases of frequent infection, or if they are very large or they're polycystic. Just wanted to show you here where the transplanted kidney is attached and where the diseased kidney is left in its place. In cadaveric kidney transplants, the donor kidney is harvested in an operating room while the donor is still maintained on life support to ensure organ viability. If the kidney is not transplanted immediately, it is preserved using one of two methods. The first is pulsatile perfusion, where the kidney is perfused with a cold preservation solution, which helps maintain tissue viability by providing nutrients and removing waste products. Or the second is through cold storage, where the kidney is placed in a cold solution, which slows down metabolic processes to reduce the risk of damage. Though kidneys can be preserved for up to 72 hours, most professionals aim to transplant within 24 to 36 hours to minimize complications. Delayed transplantation increases the risk of issues such as delayed graft function due to acute tubular necrosis, which can affect the kidney's initial function after surgery. Standard post-op care involves effectively using medications, commonly for the donor to experience more pain than the recipient due to the nature of the surgical procedure. You want to monitor the incision site for signs of infection, ensure proper wound dressing, and provide instructions for keeping the area clean. Encourage regular use of an incentive spirometer to maintain lung function and prevent post-operative pneumonia. Early mobilization is encouraged to prevent complications like deep vein thrombosis and to promote faster recovery. Closely monitor the kidney function by checking blood tests such as creatinine and BUN levels and urine output. Any changes can indicate complications. Regular blood work, including electrolytes and blood counts to assess the patient's condition, is also warranted. You want to measure urine output frequently to ensure the transplanted kidney is functioning properly, and also monitor for signs of internal or external bleeding, particularly around the surgical site. Provide emotional support as patients and donors may experience stress and anxiety post-transplant, and your patient must be educated on wound care, medication regimen, and signs of complications. Also, you want to schedule follow-up appointments with the surgeon and arrange for outpatient lab work to monitor transplant function. Additionally, I want to emphasize critical aspects such as fluid and electrolyte balance, initial diuresis, and continuous monitoring of the kidney function. You want to focus on milliliter to milliliter fluid replacement during the first 12 to 24 hours post-surgery to ensure fluid and electrolyte balance. Recipients may experience a significant diuretic phase immediately after surgery due to the new kidney's increased filtering ability, intraoperative fluids, and initial inability to concentrate urine. Continuously assess electrolytes and kidney function as it is necessary to detect any complications such as ATN, so anticipate frequent lab draws in your order sets. The risk of ATN is particularly relevant for cadaveric kidneys, which may require a longer period to establish adequate urine production. In contrast, living donor kidneys often produce large volumes of dilute urine promptly. Some patients may need dialysis until the newly transplanted kidney establishes sufficient function. Please note that the sooner the kidney starts working effectively, the better the prognosis for that patient. Teaching and monitoring should include prevention of infections in the immunocompromised post-transplant state, so your patient is on neutropenic isolation. Frequent measurements of urine output, like we mentioned before, to assess the new kidney's function. You want to do regular blood tests to monitor kidney function, electrolytes, and detect early signs of rejection. Obtaining daily weights is also important. It helps in fluid balance assessment, ensuring the patient's recovery is on track. Any changes or abnormal findings should be reported promptly to the physician. Additionally, post-op care should include regularly assessing the surgical site for signs of infection and reinforce the dressing as needed. You want to teach the patient about proper wound care to promote healing and to reduce the risk of complications. Provide detailed instructions about the various medications, including immunosuppressants, pain medications, and antibiotics. Ensure the patient understands the importance of taking these medications as prescribed to prevent rejection. You want to monitor bowel sounds and gradually introduce the patient's diet as ordered. Advise on a balanced diet that supports recovery and kidney function. Assess the patient's pain levels and provide appropriate pain control measures. Instruct the patient on using pain management techniques and medications safely. Teach the patient to turn, cough, and use a incentive spirometer to promote lung expansion and prevent post-operative complications like pneumonia. Encourage early mobilization and a gradual increase in activity. This helps prevent blood clots and promotes circulation, which aids in overall recovery. Educating the patient about these post-operative practices is crucial for a smooth recovery and long-term success of the transplant. Your post-op teaching is done at the bedside, and you really want to focus on educating the patient on the medications, their doses and indications, especially focusing on immunosuppressants. Explain the signs and symptoms of organ rejection, and emphasize the importance of contacting healthcare providers if these symptoms occur. Finalize the arrangement with the outpatient pharmacy and lab services to ensure smooth access to medications and lab monitoring. Schedule and discuss follow-up clinic and lab appointments for ongoing assessment and support. We want to encourage practices that promote health, including good hygiene, to reduce infection risk. Discuss precautions related to vaccinations and travel, including potential exposure risks. Potential complications of kidney transplants are due to immunosuppressive therapy. Recipients are at risk for bacterial, fungal, and viral infections. The patient might develop secondary malignancies. This can arise due to long-term immunosuppression. They are also at risk for recurrence of disease, cardiovascular disease, and, of course, rejection. Patients are taught to identify signs of organ rejection and report them promptly. To talk about rejection and what you should teach your patient, there are different types. In the hyperacute rejection stage, this occurs within minutes to hours after a transplant, typically within the first 24 hours. Accelerated rejection usually develops within 2 to 4 days. Both types are characterized by rapid vascular destruction of the donor organ and are caused by a immediate antibody-mediated reaction resulting from pre-existing antibodies against the transplanted organ. Unfortunately, there is no treatment for hyperacute or accelerated rejection. In these cases, the transplanted organ must be removed. The transplant patient is also at risk for acute organ rejection following a kidney transplant, which can typically occur within 3 to 14 days, but may happen up to 6 months post-transplant. Acute rejection is primarily caused by a cell-mediated immune response from lymphocytes. It's relatively common, especially with organs from cadaveric donors, and is usually reversible with immunosuppressive therapy. Symptoms of acute rejection include tenderness at the transplant site, fever and malaise, reduced urine output or oliguria, increased creatinine levels. At least one episode of acute rejection is often expected, emphasizing the importance of continuous monitoring and prompt intervention. Chronic rejection in kidney transplants occur gradually over months to years and is an irreversible process. It can be the result of multiple acute rejection episodes. The transplanted kidney becomes inundated with T and B lymphocytes, which cause ongoing tissue injury, fibrosis, and scarring. Unfortunately, there is no specific treatment for rejection, and care is primarily supportive. Eventually, the recipient may need to resume dialysis as the function of the transplanted kidney declines. Both T and B lymphocytes play crucial roles in the immune response against the donor organ. Think of B for humoral, and when you think of humoral, you think of fluids, so it's in the blood. And think of T as intracellular. So T lymphocytes or T cells are the primary mediators of acute rejection. They recognize the foreign antigens presented by the donor organ and become activated. Once activated, T cells release cytokines, which promote an inflammatory response, recruit other immune cells, and directly damage the transplanted tissue. B lymphocytes are responsible for producing antibodies. In acute rejection, they recognize antigens from the donor organ and produce donor-specific antibodies. These antibodies bind to the donor's organ cells, leading to further immune-mediated damage and potential destruction of the transplanted tissue. The combined action of T and B lymphocytes leads to inflammation, tissue injury, and can result in graft failure if not managed promptly with immunosuppressive therapy. Graft versus host disease, or GVHD, occurs when immunocompetent cells from a graft, which is the donated organ or tissue, attack the host body. This condition commonly arises when the host has an impaired immune system and receives an organ containing white blood cells capable of mounting an immune response. GVHD typically manifests within 7 to 30 days post-transplant. The main target organs are the skin, GI tract, and liver. Prevention involves using immunosuppressive therapies or irradiating blood products to prevent white blood cell activity. Management of GVHD may include the administration of steroids to suppress the immune response. GVHD can also occur after blood transfusions, especially if the blood products contain active immune cells that recognize the recipient's body as foreign and launch an attack. Switching our focus on transplant medications, specifically immunotherapy in transplantation. In allogenic transplantation, the success of the procedure depends on suppressing the recipient's immune system to prevent it from attacking the transplanted organ, which is also known as the allograft. This is necessary because the immune system naturally recognizes the allograft as foreign due to the differences in antigens, particularly human leukocyte antigens or HLA. Now remember that the transplanted patient will require lifelong immunosuppression. The recipient's immune system must be continuously downregulated or suppressed because the presence of the allograft's antigen is constant. Lifelong immunosuppressive therapy is necessary to prevent rejection, which could be either acute or chronic. Also remember that the patient must be immunosuppressed through medications, and balancing immunosuppression is crucial because excessive immunosuppression can increase the risk of infections and malignancies, while insufficient immunosuppression can lead to graft rejection. Regular monitoring of drug levels, kidney function, and signs of rejection is essential to manage the patient's response to immunosuppressive therapy. Immunosuppressive therapy is a cornerstone of post-transplant care, ensuring the long-term survival and function of the transplanted organ. As I said before, immunotherapy in transplantation is crucial for preventing the recipient's immune system from rejecting the transplanted organ. The therapy typically is broken down into different phases. First is the induction therapy phase, where drugs are administered immediately before, during, and after the transplant to prevent acute rejection. These drugs can help to suppress the immune system aggressively to reduce the risk of early rejection. Then we proceed to maintenance therapy, which involves a combination of different immunosuppressive agents to lower individual drug doses while still providing an effective synergistic response. Commonly, a dual or triple therapy approach is used to minimize drug toxicity while maintaining the immune system's suppression. The goal of maintenance therapy is to ensure the recipient's immune system remains downregulated as long as the transplanted organ, which in this case is like the antigen, is present. So this requires a lifelong commitment. Calcineurin inhibitors such as cyclosporin, also known as Sandimmune, Neurol, and Gengraph, and tacrolimus or tacrolimus, also known as Prograf, which is what you would mostly see in practice, are among the most effective immunosuppressants used in transplantation. These drugs work by preventing the cell-mediated immune response against the transplanted organ, thus reducing the likelihood of rejection. Again, immunosuppressive medications like cyclosporin and tacrolimus play critical roles in preventing organ rejection post-transplant. Cyclosporin functions selectively and reversibly inhibits T cell activation, which helps prevent the immune system from attacking the transplanted organ. Side effects include nephrotoxicity or kidney damage, hypertension, nausea, and hyperlipidemia. Tacrolimus functions to inhibit helper T lymphocytes, which play a key role also in the immune response. It commonly causes tremors, headaches, diarrhea, hypertension, renal dysfunction, hyperkalemia, hypomagnesemia, hyperuricemia, or high uric acid, and hyperglycemia. Both of these drugs are cornerstone therapies in transplant immunosuppression to ensure long-term graft survival while balancing the risk of adverse side effects. Another immunosuppressive medication is called mycophenolate mofetil. It's used in transplant, again, to prevent organ rejection. It functions to inhibit the proliferation of T and B lymphocytes, which are crucial in the immune response, as you can remember. By doing so, it reduces the formation of antibodies that can target and reject the transplanted organ. It has a high incidence, though, for gastrointestinal side effects, including diarrhea, nausea, and vomiting. Additionally, it can lead to severe neutropenia, which is a decrease in neutrophils, and reduced platelet counts, which can increase the risk of infection and bleeding. Mycophenolate mofetil is often used in combination with other immunosuppressive agents to achieve optimal graft survival while managing side effects. Immunosuppressive therapy using corticosteroids also play a crucial role in transplant medicine. Corticosteroids functions to suppress the inflammatory response, inhibit cytokines, and prevent T cell activation and proliferation. Common medications are prednisone, which is a common PO steroid, and methylprednisolone, typically administered intravenously, especially in acute settings or during the induction phase post-transplant. These medications help in reducing the risk of organ rejection by modulating the immune system, hence promoting transplant success. Prednisone is a corticosteroid, as mentioned, commonly used as an immunosuppressive medication in transplant patients for both induction and maintenance therapy. It works by reducing non-specific inflammation and deactivating T lymphocytes, which helps in protecting the graft from rejection. Side effects again are GI bleeding, sodium and water retention, delayed wound healing, hyperglycemia, osteoporosis, mood alterations, acne and hirsutism, muscle wasting, skin breakdown. It is typically tapered to a lower maintenance dose, especially when combined with other immunosuppressive medications. So remember, your prednisone needs to be tapered down if you are changing doses. And prednisone is also known by its brand name Deltazone. Monoclonal antibodies such as muromonab, CD3, daclizumab, and basiliximab are used in transplantation to treat and prevent acute rejection. These drugs work by targeting specific components of the immune system to prevent it from attacking the transplanted organ. The names of these drugs typically end in MAB or MAB, indicating that they are monoclonal antibodies designed to modulate the immune response. Immunosuppressive therapy in transplantation can lead to several potential complications, including secondary infections, which are due to the suppression of the immune system. Transplant recipients are at a higher risk for infections, including bacterial, viral, fungal, and opportunistic infections. Close monitoring of prophylactic treatments are often necessary. Drug toxicity, because immunosuppressive drugs such as calcineurin inhibitors, corticosteroids, and monoclonal antibodies have side effects that can include nephrotoxicity, hypertension, metabolic disturbances, and GI issues. Regular monitoring of drug levels and adjusting dosages can help manage toxicity. If you are ever working in a transplant unit, you will see that your transplant team is very regimented in terms of the times that your blood levels for your drugs, especially for Prograf, are drawn. They want that at 5:30 so that they could dose the next medication dosage properly. And they really, really don't like it if it is done at any other time other than at 5:30. They also run the risk of for secondary malignancies because long-term immunosuppression can increase the risk of developing cancers, especially skin cancers and lymphomas. Therefore, patients require routine ongoing screening to detect and treat these malignancies early. Proper patient education, frequent monitoring, and a tailored approach to immunosuppressive therapy are crucial in mitigating risk. Nursing management of immunosuppressive therapies include monitoring for signs of superinfection, being aware of oral thrush as a common complication, educating patients about drug interactions, including those with grapefruit juice and other medications like calcium channel blockers and St. John's wort. For continuing care after a kidney transplant, it's essential to prevent infections since immunosuppressive medications reduce the body's ability to fight infections. It is crucial to maintain a good hygiene, avoid crowded places, and practice caution to minimize the risk of exposure to infections. Adhere to the treatment regimen and follow the prescribed medication schedule strictly. Any deviation can increase the risk of organ rejection. Remind your patients to attend regular follow-ups and regular checkups with healthcare providers since they are essential to monitor kidney function, immunosuppressive therapy levels, and overall health status. Monitor fluid status by keeping track of daily weights and urine output to assess fluid balance and detect any early signs of complications such as fluid retention or dehydration, and maintain a healthy lifestyle including a balanced diet, regular physical activity, and avoiding smoking or excessive alcohol intake. This ongoing care is critical to ensure the success of the transplant and the patient's long-term well-being. Thank you for your time and attention. Please proceed to the remaining renal and dialysis lectures in this module. I look forward to addressing any questions you may have. Have a wonderful day.